For the next little bit here, I'm going to be going through, for many of you, what will be a quick review of what the traditional epidemiologic study designs look like, but to give you a slightly different bent about how we looked at them to implement them in the experiments you're going to hear about for the rest of the day. I'll draw your attention to two other sheets that were in your packet. One is, I guess, a reddish color. It says literature settings. The other one says methods used, which is green. I'm going to highlight some articles from the peer review literature as kind of examples of how some traditional epidemiologic studies were done and published in the literature, and how the analog looked within OMOP. I think Patrick in the subsequent presentation is going to pick up on some of those examples as well, but just wanted to familiarize you with that, and I think the references are also in your material. I want to orient you a little bit to some of the cartoons that you're going to see that hopefully will make this material a little bit more accessible. So for some of you this will be a review, for others it may be a refresher, it may be good for you to see. So we have in these data sets patients. They're all different in one way or another. Some are exposed to target drugs that we're interested in. Some of them have events that we're interested in, target outcomes, HOIs. They go by a lot of different names. They also have other conditions, comorbidities that may be of interest, that may modify their likelihood of experiencing other events. So this is not an atypical situation that you see in one of these databases where you have a patient who's experienced the event you're interested in while they are exposed to a drug that you're interested in, but they also have a few other conditions that you may or may not be interested in. Of course, they also are taking other medications that may or may not be a part of your thinking in instituting methods or studying their events. So patient A, as an example, has a little bit of everything going on. Patient B is slightly different, just as an example, where they've experienced the target condition or the HOI three times during the course of our follow-up, but they also have other conditions, they also have other drugs, and they have 2 periods of exposure of interest to us, at least in a particular study. Another example would be patient C, who's exposed for the duration of our ability to look at their healthcare use. They have no gaps in that exposure. They do have other comorbidities. They do experience an event. They do take other medications that overlap with the drugs that we're interested in. Here's just another variation of a patient who has exposures to the drugs we're interested in, exposures to other drugs, but they're not experiencing an event that we're interested in. They do have comorbidity. So you can just see these are various permutations of different types of patients that you would expect to see in some of these massive databases. This last one is a patient who's not exposed at all, as best we can tell, to the drugs we're interested in, but still experience events and are taking other drugs, and in fact experiencing multiple events that we're interested in. And finally, a patient experiencing no events and is not exposed to the drug we're interested in. So you see the absence of the yellow exposure bar and the absence of any red stars. So that's the kind of cartoon approach that I'm going to use to help explain how we instituted some of these study designs. Now, most of us who went through the traditional programs pretty much learned about the study designs being case-controlled cohort studies. Depending on when you were educated or where, you might have gotten into self-controlled designs. So I'm going to kind of bucket it along that way. Let's start with the new user cohort design. Again, let's pretend that A through F represents the population in your database. You can see that you have a lot of choice here as to how you might select people to be in your cohort. So for a new user cohort, based on, it's kind of obvious, we want to assure ourselves that we're catching people at the beginning of their exposure time to the drug of interest. So for instance, patient C, we really don't know how long they've been on the drug of interest because their exposure is consistent and started with the very first instance that we see of them in the database. And we've all seen these types of patients in the data, so they'd probably be excluded because they don't meet a washout definition or a clean period prior to exposure. That gives us confidence that they would have been newly exposed. Patient E was excluded because they also don't have a washout period from a comparator drug. So we'll take them out of our analysis for now. And we are looking specifically at those patients where we have a washout period, where we see the beginning of exposure, and we're going to compare them to some other group where we also know when they started their exposure periods, and we're basically going to compare the rate of events between these two groups. Fairly straightforward, fairly typical new user design. We tend to ignore in almost all of these designs events and exposures that occur after the events of interest. So the focus is on comparing rates among patients exposed to a target drug relative to rates on a comparator. We usually use relative risks, and the key thing is how we define or how long we require that washout period, that clean period to be to make us feel confident that we are getting new starts or new users to a given drug. This is a slightly different representation, but it's meant to reflect all of the possible decisions that one needs to think about when instituting just what seems to be a fairly simple new user cohort design. We have to think about how long do we make the washout period prior to the initial exposure. Those of you who've worked with these databases know that the more restrictions you put on, especially claims data, the smaller and smaller your population becomes. The average follow-up time is not as long as we would hope. So some people will shorten these time windows to the point where they're marginally comfortable that they're getting what they think they're getting. But obviously the longer these washout periods are, the more confident we can be that they are actually a new user. And then there's all kinds of thoughts that we need to have about how long do we follow these people until we see an event. Do we count multiple events? At what point do we allow covariates and comorbidities to enter into our thinking? Do we accept covariates that occur after the index exposure? There's all kinds of decisions about adjustment strategies and matching strategies. And again, my role here is not to get into the detail, but to just orient you again to the study design. I believe Patrick and David will be getting into this in much more detail. So as an example, here's a cohort study in a Canadian database taken from the literature. You don't need to read this. We've basically excerpted for you. They use administrative claims from the Quebec provincial data. It's a cohort design. All people who received at least 30 days of therapy for tuberculosis. They required a 6-month prior clean period to make sure these were new users. They looked at that period of exposure time plus an additional 60 days beyond. That was considered the time at risk during which any events that we were interested in would be counted as related to the exposure. The outcome of interest was a new hospital admission for hepatic events as they define them, and so on and so on. They did 2 adjusted odds ratios in this first column here. Let me see if this pointer, there we go. This first column just adjusted for prior hospitalization, Charlson score, and some selected comorbidities. The far right column had a lot more of the comorbidities specified in that. And you see they come up with an odds ratio for those over 65 of 6.4 with a fairly wide confidence interval. Fairly typical what you'd expect to see in a cohort design, new user cohort. Here's the OMOP version of taking those same concepts and putting them into play in the OMOP arena. So the database we used was the Market Scan Medicare database, cohort design, again focused on the exposure of isoniazid, 6-month washout period, how we defined the unexposed cohort and the time at risk. which covariates entered into the model, which were very similar to the ones in the literature report, and the propensity score stratification technique that was used. And you can see on the bottom red or orange, showing up as red, is the OMOP result. The blue above is the result for the over 65s from the Canadian study, and you can see they're pretty similar. This gives us some reassurance that we're not trying to exactly replicate what was going on in the published study. The populations are different, but it does allow us to feel comfortable that we can take some of the complicated decisions that you would expect to find in the literature and turn these into risk identification tools. And that's really what this exercise is about. Let's move on to case control designs. Again, remember, case control designs, you're starting with people who've had the event, and you're essentially looking backward to compare between people who've had the event versus those that didn't to determine exposure status. So if we go back to our fake population, we're obviously going to be focusing on people who meet the definition of our event. And here we've selected, and they should be popping out of the screen at you, these 4 people. They become our cases. We, in some way, select controls, whether they're matched directly or through some other selection process, so that we have comparable groups to compare to. We ignore observations that occur after this index event. They don't come into the analysis, and they're usually not considered. We look back for some window of time to look at their exposure status, and that is a comparable look-back period for both cases and controls. And from there we have our case control study. And there are a lot of decisions that go into this. As anybody that's been involved in case control studies would know, how many controls you match per case. Again, depending on when you were educated, we were taught that more than three controls per case was inefficient. Then all of a sudden, with large databases, people said, take as many as you want. It's not a matter of efficiency so much. And then some people talked about overmatching, but needless to say, there are a lot of decisions that can be made about just the number of controls, let alone how you're going to identify them and how you're going to match to make sure that you can account for some potential confounders, whether or not you nest the entire study within a given indication, how far back you look for exposure time, so on and so forth. But the point is, there are a lot of decisions to be made. Now, in the OMOP language, those are called parameters, essentially, and you'll hear more about that later. Moving ahead, we've got an example here from Sammy Suisse's group. For some reason, we're on a Canadian kick here. And you see a case control analysis of looking at clopidogrel in the GPRD, General Practice Database, first episode of upper GI hemorrhage. And again, here are some of the selection criteria that were made. They had to have a minimum of 3 years of observation time, which is a lot more feasible in some databases and not others. 10 controls per case matched on index date, age, and practice, and a number of covariates that were relevant based on other studies in the literature. And you see that they had an adjusted rate ratio of 2, with confidence intervals that were fairly tight and well above 1. Our instantiation of this approach looked something like this, and I'm not going to read you the slide. I think you're capable of doing that. Very closely matches their analysis, and you can see that the results line up fairly closely with the analysis reported from Suisse's group. Again, case control study. There are other examples of case control studies. This is NSAIDs and acute MI, again in the GPRD data. Again, looking at just one of the exposures, and here we have an adjusted odds ratio of 1.4, not significant. The confidence interval embraces 1. A number of covariates, some of which you'll find in other databases, others which you won't. Particularly BMI and smoking, again requiring a 3-year observation period. And here again you have our implementation of this now in the GE database, which is an outpatient U.S.-based electronic health record. And you can see it's remarkably close with virtually the same settings, same parameter settings across. But the point is, again, we can take different approaches, same study design, and feel reasonably comfortable that we're able to take these study designs and turn them into eventually what will be seen as risk identification tools. Wayne Ray's paper, which many of you are familiar with, this is in Tennessee Medicaid, again, case control study. And I'm going to just skip through this because my time's getting short. Our version of Medicaid, not limited to Tennessee, looking at incident renal failure, 10 controls per case, and you see our relative risk was coming out about 1.3, theirs was about 1.6, still in the same ballpark, still reassuring to us. Let me shift gears to self-controlled case series. I'm curious how many of you were at the ISPE meeting, which I believe was in Denmark, where the feature presentations were about self-controlled designs. Anybody attend that? It seemed that year, for whatever reason, self-controlled designs were featured. If I remember correctly, one of the keynote speakers talked about the entire population of some of the Nordic countries being seen as a potential cohort to be studied. So the self-controlled designs kind of fall into two camps. One are those restricted to just people who've had the event, and the other, which I'll get to within my allotted time, will be those people who've not necessarily had the event but are still able to contribute exposure time. And here again, we'll just walk through our cartoon. Self-controlled design it relies on people having exposed and unexposed time for the exposure of interest. So patient C gets excluded, patient D gets excluded because they didn't have any events. Remember, they have to have time on and time off as well as having had an event. It's essentially a before and after design if you're a social scientist. And we get down to just the top two who would meet our population definition for being included in a self-controlled case series approach, notably because they have both exposure time and unexposed time, but they also are experiencing events. So it's self-controlled case series. What we're really looking at is a comparison of the rate of events while exposed versus the rate of events while unexposed within the same person. So you're inherently controlling for a lot of confounding that might occur if you're comparing across people. Your person becomes their own control. You're ignoring, you'll notice you're ignoring the other exposures and to some extent the other comorbidities. If you do the simple calculations, patient A is having one event during their 3 months of exposure and experience no events when not exposed, as opposed to patient B who's having 3 events, 2 of which occur while they're on exposure and 1 event during a period of unexposed time. Many decisions again here to make, mainly around surveillance window decisions. Which events to use, whether it's the first event or all events. And again, I think you'll hear more about this in subsequent discussions. There are multivariate versions of this that include adjustments for comorbidities. This is an article I think that gets cited quite frequently, using a self-controlled design, looking at SSRIs and upper GI hemorrhage, using the THIN database, again a general practice database from the UK, looking at first diagnosis of GI bleed, on and off SSRIs, minimum of having 106 months of exposure or observation time, excuse me. And here is our version of how that was put together again in the GE centricity, which is a outpatient electronic health record, and you can see that the results line up fairly closely and again fairly reassuring. Self-controlled cohort is kind of the cousin of this design, which I had mentioned before, where you're looking at not only people having the event but people who are exposed not having the event. So we exclude the people who are not on the drug of interest because they're not contributing exposure time. and we're focused on people who've had some exposure to the drug of interest, and we're basically comparing the rate of events during exposure or post-exposure with the rate of events while not. And you can see that patient D, even though he's not having events, is contributing exposure time to the calculation. And again, here we have a number of parameter selections to be made and decisions about which outcomes to be used. We also have some decisions about pre-exposure surveillance windows, where it should begin and where it should end. Again, this is meant to be time on drug, time off drug kind of approach. So you will find this, I believe, in your material, but in summary, these are the methods that form the backbone of the experiments you're going to hear about for the rest of the day. Two types of study design, so methods that fall into that self-controlled cohort approach are the temporal pattern discovery and observational screening, which you will hear about in some detail in subsequent slides. So in summary, we tested a range of designs. We lined them up and looked at literature as kind of test examples to see how our ability to institute similar designs and similar questions would work. We looked at all the decisions that go into them, particularly focusing on how each one dealt with potential confounding. We did explore some more advanced and some novel approaches, which again will be reviewed in a little bit more detail later. A lot more detail can be found on our website. As many of you know, everything that we do is posted on the website, including all that you would need to institute these methods against the OMOP common data model in the privacy of your own home. But in summary, we've got many decisions that need to be made, a number of parameters that need to be set, and you'll hear more from Patrick and David, I believe, on how that is done.